us are at greater risk for disease because of our genetics. However, when we are living in our communities and the behaviors we choose, these actually determine a lot as to how that disease progresses or whether it does. And that's so important to recognize in our mental health, that our lifestyle and where we live, work, play, learn makes a huge difference as to how our mental health shows up. And the medical care, it catches us when we need it. Next slide. As a person who's been in public health for a while, I've heard more and more recently people recognizing the phrase moving upstream, and it's being used frequently, which is exciting. It's really important. And for those who may not fully have heard this story, moving upstream is the story of a bridge on the upper right. And it's broken. People cannot get across the river. As a result, there are people struggling to stay alive and they're starting to drown. People come and they help them. They are pulling them out of the water. They're getting them to the hospitals to be healed. And when we're doing that, it is really hard for someone pulling someone out of the water, giving them the buoy, to leave and go upstream, because that means we lose a life. The great thing about everyone here today is that we are all at different places along the river. Some of us are downstream. We're saving people. Some of us are closer to the bridge. We're catching them early. We're getting them to their primary care provider to get them help, to a therapist. And some of us are upstream in communities. As a result, no one needs to leave where they are along the river. We're all in the right place. And that's the important thing of moving upstream. None of us have to be good at everything. We all have an important role to play. Next slide, Emma. So most of you have probably seen this. Some of you may have not. This is a socio-ecological model for change. What has been shown is that a person is more likely to have improved health when every single one of these factors, their individual life choices, their knowledge and skills, their network of support around them, where they live, learn, work, and the values and environment surrounding them are all critical to have a person be whole and healthy, mentally and physically. There are a lot of ways that we can do this in the world of mental health, and I want to elevate these. Dr. Douglas mentioned risk and protective factors. These are critical. These are those things that either influence our genetics to increase the likelihood of us having mental health issues or protect us from that. So I'm going to go through these quickly. You all can read, but individual, it's our knowledge and ability to address our own environment. It's whether we engage in substance use. It's our temperament. It's attachment. Then you get to the interpersonal network, the next section, and you're going to see that the people around us make a difference. If we have poor parenting, if negative family events, if parents or family members use alcohol or drugs, a person's more likely to have some poor mental health. These are risk factors. And then when you get to organizations and community, you'll see that the people around us and the systems around us also affect us. Community violence, poverty, Grace mentioned these, poor academic achievement, the schools, these all impact our health. Then if you go to the next slide, you will see the positive protective factors. These are the things that decrease our likelihood of poor mental health, positive development, good self-esteem, self-regulation, and problem solving. In our interpersonal network, you will see that the people around us that are providing structures and limits, supportive relationships, they make a difference. And then when you get to our community, where we live, work, play, learn, you'll see that it's mentors and supportive development, opportunities for engagement where we are, positive norms, safety. These all make a really big difference. And this is a lot. It can feel overwhelming. There's a lot here. But if you look on the next slide, there are just a few themes, and it's what we can all do together. Social connection, social cohesion, safety, stability, and engagement. These are so important as we're looking at mental health. And it's something that we can do as professionals. The talent in this room is incredible. It's also something we can do as members of our community. And this is what we can influence. And it's so important. Next slide. As I mentioned, right, everyone has a role to play along that stream. Every single person here and those who aren't here, we all have an important role to play. We identify our strengths and we leverage existing efforts. We create systems so that the things that are happening, we connect them so it's easy for people to be supported wherever they are. We can identify and fill those gaps, identify and remove barriers. That word is missing. But as Grace mentioned, if we are doing all this, we are creating equity for everyone. But we need to make it simple for folks. And that means we all need to know what we're doing and work together to do it. So I'm going to show a quick video of how we all work together as described by a chemistry teacher in a movie. Are we going to be able to do it?
Let's see, Patty, you have that queued up, right?
Thanks, Patty.
We lost you.
Whoa, what's going on, Mr. Voss?
Biology, Derek.
Fair enough.
Can someone tell me what happens when a cell stagnates?
Okay, no one's listening to me.
I will try again. Anyone know what happens to a stagnant cell?
What's he doing on the table?
I don't know, something about cells.
Malia,
It's not good.
did you hear that? It ain't good. People, a cell that is not in motion is not a productive member of the system. It ends up assuming all the other cells are gonna pick up the slack somewhere, but they don't. In fact, they imitate the stray cell until basically the whole organism begins to die. Yeah, but you know what? Biology is an amazing thing. And here's the good news. All that decays can be restored. It's just hitting anybody.
Like how a cut heals.
Like how a cut heals. Brian, my man.
Ah, look, you got one.
And once that cell is back on track, it creates energy amongst the other cells. That's what happens.
It starts getting a little movement going. It gets a little rumble.
Can I get a little rumble from everybody? Everybody just rumble in your seats right now for me. Just rumble a little bit. Okay, no rumble, that's fine. I'll be the lone rumbler up here. That's what I am. I'm a lone rumbler. But then the cell starts banging into the other cells. And the cells push back and go, hey, what are you doing to me? They hit into another one. Hey, don't do that. Hey, that's my friend. You don't even know him. You don't know me either. I know you, we work together. Because then they hit a rhythm. They all hit a rhythm, and this is the beginning of the restorative process. So now, even if the entire system is close to dead, what happens? Martinez, come on, give me something. Oh no, not today.
Oh no, not in my house. No, 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 no.
Look out, here we come. Don't look up my pant leg, Derek. You're better than that.
Right over you.
Come on, man. What do you say? If all the cells work together, what will happen?
Entire system is healed.
Exactly. That is a sick dragon.
So we're all cells. Sometimes we want to stagnate because this is hard work. Dr. Douglas and Grace mentioned, this is the long haul. And as we figure out how to work together, there are times we're going to be bumping into each other. We're going to be pushing each other around. We won't have that energy in the groove. But over time, we're going to get the groove. We're going to get the energy. We're going to be moving together. And the whole system can be healed. Each of us have something to bring to this. And when we see a gap, there may be someone missing. But we'll continue to lean on one another and challenge ourselves to do the things that need to be done so that we're creating a whole community for everybody to be supported with those protective factors, minimizing the risk factors, and remembering that we all have a space along the stream of moving upstream. And with that, and I think the next person is Summer Gatherful, yeah? So I'm going to remind us, right? This is what it is every day. This is what it is every day. These are the contributors to our overall health and well-being. All of them important. And Summer Gatherful, who I've known for a while and respect tremendously, has worked with the governor's office over the past few years to remind us what it feels like when people are struggling and hurting. That second bit, Emma. And so it is important to not minimize either approach. We need to remove our barriers to health treatment as well and make sure that people are comfortable talking about their mental health, connecting with one another, supporting one another. And when the time is necessary for care, there is no stigma, there is no shame, there is only recognition that our mental health is our physical health and that treatment is equally important. So thanks, Emma, for letting me talk about collaboration and prevention. I'm excited for these days because together we can make a significant difference.
Monica, thank you so much. I have a big smile on my face and am definitely feeling the feels. Appreciate you kicking us off in that way. And you're right, Summer Gathercole, who is the acting deputy commissioner of the Behavioral Health Administration coming on board, is here to speak to us, to give us some updates about what's happening here. And I really appreciate you, Monica, setting the transition phase around what we hope to hear about what's happening at the state level and at the health systems level, so that we can really be focused going forward on what we can do at the local level and perhaps in complement to the health system. So Summer, I believe I saw you come on. Are you ready?
I am. Good morning, everybody.
Good morning.
And thanks for having me today. I'm super excited to be here, although I am not so sure about following Monica's and her presentation because that was very powerful. So hopefully I can kind of live up to that same expectation, but really excited to be with everyone today and give you an update on the new Behavioral Health Administration, which will be officially opening its doors on July 1st, later on this year. Just to set expectations, it will only be partially functional. It will not be 100% functional. We are taking a multi-phase approach to make sure that we are really thoughtful and intentional about executing on the functions of the BHA in the way that we want to. If you go to the next slide, this is just a quick snapshot of the Behavioral Health Administration and what it is. It is a new entity that will be overseeing and leading the behavioral health system in Colorado. If there's nothing else that you hear me say today, but I would just want to make sure that you know is that this is a change to our system. It's not necessarily a change about how the Office of Behavioral Health is doing its work. It's not about how HCPF is doing its work. It's about how we are all collectively doing our work together. One of the things that we identified over the last couple of years is that in Colorado, we spend about $1.5 billion, and that's public behavioral health dollars, across 13 state agencies and the judicial branch in over 120 different programs. We are not coordinated. It's really convoluted, and more than anything else, it's really hard for the person who's trying to seek services to navigate our very convoluted system. And that is probably the thing that we heard most from all of the different public testimonies that we held back in 2019 and 2020. We had hundreds of Coloradans from across the state come and share their experience and give their recommendations on what they would want to see differently. So the BHA will be kind of leading the coordination of behavioral health efforts across all of those different state agencies, across all of those different, with the judicial branch, across all of our different providers, and really making sure that we're streamlining our system. You know, when we looked at that kind of deep dive analysis and found that $1.5 billion in those, you know, over 120 different programs, what we didn't find was a lot of duplication of programs. We actually found a lot of duplication of processes, which is kind of how we came to the model of the BHA that we have now, which is where we have the BHA that is kind of working with all those different state agencies. And by doing that, we're talking about setting up formal agreements between the BHA and the 13 different state agencies that really outlines how we're defining data, how we're collecting data, how we're reporting on data, how we're working together in a way that we haven't done before in a much more intentional and thoughtful approach. So we're also looking at, you know, of course, one of the other things you heard is that we need to make sure that we are engaging people with lived experience and their family members who are helping us to design or redesign our system. So not just giving input, not just giving feedback, but really, really engage deeply. So what you see here on this screen is just a snapshot of some of the, oh, you can go to the next slide, that's good. Thank you, Emma. So what you see here is just a snapshot of some of the functions of the Behavioral Health Administration. We have a long, long list of everything that we want the BHA to do, but I'm going to give a couple of examples of how we expect that the BHA will be changing our system. So if we think about our payment policy, and right now, you know, as I said, with 120 different programs of behavioral health programs across the state, that's a lot of different funding streams, a lot of different dollars. One of the things that the BHA will be doing is actually starting to track all of those public behavioral health dollars across the state so that we can say to regions and to counties, here's how much money is coming into your county, here's how it's being invested, and here are the outcomes. It also gives us an opportunity to look at how do we better grade and blend some of our funding streams to make sure that we make our resources go even farther and be more meaningful. So that is one example. It's going to take us a few years to get there. It's not something that we're going to be able to do right away. I am excited to share that the BHA and HCPF are already working on this initiative and expect to have the integration of our resources tracking in July of 2023. So that's the first step. And then the longer step is how do we get the rest of the state agencies to do that? Another kind of example I'll give here is our legislative think tank. So if anyone's following legislation in Colorado around behavioral health the last couple of years, you know that there's been lots and lots and lots of behavioral health legislation that has been introduced over the years. And they're all for different agencies. And that's a lot of how we came up to getting these 120 different programs. We want the BHA to be a legislative think tank so that anyone who has a public policy idea actually goes to the BHA first and says, let's talk about this public policy idea. Let's talk about which agency should own it, what the impact is, how can we help form that, that piece of legislation or public policy. So that's another idea of just how we're hoping that the BHA will be very, very different. Again, we want the BHA to be defining data across all of our state agencies, across our system the same way. We want to make sure that we're collecting data the same way, really kind of streamlining all of our different processes so that we are being more efficient and working together across our system, again, in a very collaborative fashion. So if we go to the next slide, What I'm going to share is that later on this week, we do expect that our legislation for the Behavioral Health Administration will be introduced. I feel like we've been saying that for a little while now, and part of that is because it is a massive, massive bill with over 100 pages of details in there. So it's a long bill, which is why it's taken us so long to get there. But I wanted to highlight just some of the key pieces that are in the bill, because I think that will help everyone to understand how we're really wanting to, how we want the BHA to function. So first is starting with our leadership piece. I think everyone hopefully has heard that we did name, Governor Polis named a new commissioner for our Behavioral Health Administration, Dr. Morgan Medlock, back in January. She started already. She is fantastic. And one of the things I love most about her is that she always comes back to what's best for people who are looking for services, what's best for our Coloradans. It's always about the people. She always brings the conversation back to that. I think the exciting piece about our commissioner too is that it's a cabinet level position. We have not had a behavioral health person at a cabinet level position in Colorado before. So it's a huge step towards, I think, highlighting how important this role is to making sure that the commissioner is working with her peers and other cabinet members across those different state agencies. We also expect that there will be a statewide advisory council for the BHA. That advisory council will have no state people as voting members. It will only be our stakeholders from across the state. So the advisory council will include people with lived experience, their family members, people from schools, our tribal representation. I mean, just we have a kind of a dream wish, if you will, of like everyone that we want to make sure is represented on the advisory council. But that advisory council is really expected to kind of give some feedback to the BHA and the commissioner, to give some guidance, to talk about the emerging trends that we're seeing in communities, and to also make sure that they're sharing with the BHA, here's what's working and here's what's not working and here's what you need to do better. So we're also going to be looking at, performance monitoring across the system. In Colorado, we do a great job right now of monitoring all of our different processes, but we need to do a better job of monitoring our performance and our outcomes. So people's lives should be better because of their interaction with the behavioral health system. And that's really what the outcome that we're looking for. So we want to make sure that we are monitoring the system. And again, that means holding all of our sister agencies accountable to meeting the standards that we have laid out for all of our contractors and our providers. When we did a lot of stakeholder engagement last year, we heard a lot about the need for a grievance and appeals process across the system. So right now, HCPF has its own data, the Division of Insurance has its own data and system to approach grievances and appeals. We want to pull from that data and then also figure out what other processes should we put in place so that people feel that there is a complaint, grievance, and appeals process that is meaningful, and so that they're not getting passed around from one place to another. I like to call that kind of the not it game of, we do a great job in state government of saying like, oh, that's not our government agency, that's actually this other government agency. And so we need to stop that and make sure that we are addressing the grievances that we're hearing, the complaints and grievances that we're hearing, that we're identifying the pattern problems across the state, and that we're also doing something and redirecting resources to address those pattern problems when we need to. I'm going to skip around on this a little bit because I know we don't have a ton of time, and I want to make sure that if we can have questions, that we have a chance to do that too. So I'm happy to do that. But a couple of other things I'll just highlight that you'll see in the bill. One is that we're really kind of redefining our safety net services across the state and saying that, we want to make sure that there are essential providers who are providing at least one of our safety net services in different regions of the state, but we also want to make sure that we have comprehensive providers. And those comprehensive safety net providers are providing all of the safety net services, maybe through themselves, which might be a heavy lift for some organizations because that's a lot of different services, but also maybe contracting with other providers who can provide some of the specific safety net services. What I would say here is that this is also safety net services across the continuum. So really want to make sure that, if anyone, so when we talk about the BHA, we're talking about, across our system and across our continuum. So as an example, I know we were just talking about prevention a few minutes ago with Monica. When we're talking about prevention, that is definitely going to be part of the BHA in terms of setting expectations, setting standards, making sure that we're promoting prevention and supporting prevention services in the way that they need to be. I want to make sure that people hear that as well. The big change that I think everybody will probably hear about in the BHA when the legislation or the bill draft is introduced later on this week is that we will be establishing regional intermediary structures. So currently right now in Colorado, we have ASOs that oversee our crisis system. We have MSOs that oversee our substance use disorder system. And then we have our community mental health centers that are providing those mental health services. It's very fractured. And so one of the things we want to make sure that we do is actually address the bifurcation of mental health and substance use disorder services. And one of the ways that we're going to do that is through these regional intermediary structures that will consolidate those contracts and services under this one intermediary, who then of course will be responsible for ensuring that we have provider adequacy across their region and across their continuum, and we can meet the needs of Coloradans. One of the things that will be, I want to kind of stress with the intermediaries is that they will also be responsible for ensuring that all of their providers that they work with in their region are held to certain specific standards. And again, this is where we want to make sure that not only do we have all the services that we want and need across the continuum, but that we also have quality services across the continuum. And that again comes back to the outcomes we want to see in Coloradans' lives being better and more enriched because of their interaction with the behavioral health system. And the last thing I'll just mention here around the regional intermediaries is that they will also be responsible for care coordination. So we were really lucky last year in our legislative session to get some initial funding for care coordination, which really supports the kind of the technical interface, if you will, of the services that are available across the state. And that includes services that are available through Medicaid providers and non-Medicaid providers. We're really, again, trying to make it comprehensive across the system. So the first step is the technical interface, almost like a website or an app that people can go to identify services in their region. The next piece and long-term goal of care coordination is making sure that we have the people in place. And so that really means that for especially those who have acute needs, they're working with someone who's helping them transition to different types of care, who's making sure that they have access to the services that they need. And when we talk about the care coordination, it's not just related to behavioral health, it's actually related to behavioral health and everything else that people need in order to thrive in their community. So that might be access to housing, that might be access to employment or training. So we really want to make sure that we are giving people access to all of those different kind of social service needs, if you will. So I'm not going to go into any other detail in the bill because I could go on forever. So I'm going to just stop there. And if you go on to the next page, this is just our webpage. I would definitely encourage everyone to, if you're interested in keeping up with the BHA, go to this webpage, check it out. We update it on a regular basis. We also have a section on the webpage where people can submit questions or make suggestions, but we check those kind of questions that are asked on a weekly basis and then update our webpage with the frequently asked questions again every week to make sure it's fresh. And if there's other meetings or opportunities for people to get involved with stakeholder engagement, that is posted on this webpage as well. So definitely want to encourage people to check this out if you want an update on what's going on with the Behavioral Health Administration. All right, so that was a whole heck of a lot of information. I'm going to stop and take a breath and see if we have time for questions. I'm happy to answer them.
So we have maybe time for just one or two questions. If anybody would like to ask a question, you can either just come off mute and ask the question, or you can put it in the chat. I will also say if questions do come up throughout the day that might best be for Summer or her team to answer, we can gather those and make sure that she gets them afterwards. We'll have some open communication channels to do so.
Summer, I have a question. This is Nate Thompson from Littleton School District. Just wondering, was there any conversation about the use of the term mental health versus behavioral health? I'm just thinking in the school world, behavior means a whole different thing. And I know for our young kids, they don't think about behavioral health. And I know for in the medical system it does, but I'm just wondering, was there any conversation about that?
Yeah, that's a great question. Thanks, Nate. So when the Governor's Behavioral Health Task Force first started meeting in 2019, we actually had a very deliberate conversation around using behavioral health and just deciding at that time that it was kind of the umbrella term that we wanted to use to cover both mental health and substance use disorder services. I think one of the things that the Behavioral Health Administration will probably want to revisit when it's officially open is, is that the term that we want to continue to use? And, we also want to probably explore things like, do we use mental health versus mental wellness? And, how are those words important to how we're using them? So I think it's a great question and probably something that we need to re-explore once the BHA is officially up and running. Happy to take another question if we have time.
We have a quiet group so far, but Summer, I just want to thank you for your presentation. And again, if we come up with questions throughout the day or even in day 2 of our summit next week, be happy to pass them along to you and be that communication channel. So thank you so much, very helpful. And we appreciate your time today.
You got it. Thanks for having me today, and thanks for the good work that all of you are doing. Really appreciate it.
Awesome. Okay, well, so we're going to move into the core of our presentation today. And what we wanted to do was really start with an overview of work that's been happening over the last couple of years. And so we'll start with a review of some of the assets and gaps analysis that was conducted really starting in 2020. And we did so with the support of a contractor, a health management association. Many of you on this meeting today participated in this analysis. So we wanted to share some of the things that we learned through that process. Later today, we'll show you the frameworks that we have developed to focus on mental health and suicide prevention strategies, and then a little bit about town halls that we conducted in 2021 to help support our further learning around this work. And so we'll go ahead and jump in. The key informant interviews and our assessment. So this was a fairly robust process. I'm not going to go through all of these questions, but if you're curious, the 4 broad questions and the side questions were really to help us understand what is the history of collaboration in Arapahoe and Adams counties on mental health and suicide prevention, including who are the leaders, who cares about this issue, what are our potential challenges for collaboration, and who are our champions that we must have involved. We also wanted to know about how important is this issue, and who is it that cares about this? How does the local media cover these issues? And how long has this been a priority for the community? You heard Dr. Douglas say that this has been a priority for Tri-County for more than 10 years, and probably even before then, but really understanding that. The third question has to do with funding. So what is it that's happening around funding for this, especially outside of the treatment model? And is the appropriate leadership and I think related additional resources involved in this? And so we spoke with 23 unique organizations, 35 people. Most of the organizations were either focused on Adams or Arapahoe County, with others at a regional level or state level. We talked with schools, behavioral health providers, integrated care providers, social services, criminal justice and law enforcement, crisis services, adult and child protection, and more. And we really appreciated all of the time. I will mention that all of these assessments and interviews happened in the early days of the COVID pandemic, so in April and May of 2020, which added another sort of 5th layer of questions around what the heck is happening to our system as we are figuring out COVID and the pandemic. And so we'll go into this in more detail, but really this is a big summary of the strengths of the current mental health system in Adams and Arapahoe counties and the ongoing challenges with the system. And so I'll go through the strengths here briefly, and then we'll talk about the challenges as well. And we'll come back to these issues a number of times throughout the day and into the second part of the summit. So first, in terms of the history of collaboration, a strong strength that there is a growing awareness of mental health as a community-wide issue. So we see that the role of mental health and overall health is heightened. People are getting that as an important issue. We have organizations that are willing to come to the table and discuss the challenges and potential solutions. And that we have lots of information and resources developed and available on certain topics. And then increased community services and a movement away from brick and mortar treatment offerings. And we saw this continue to grow, especially because of the pandemic and some of the issues that came up there. Another area of strength, there are collaborations happening across these counties and they're working. And here's just a couple of examples of those community-wide collaborations. One that we heard multiple times was the collaboration with school and the momentum towards school-based mental health and increasing in appropriate crisis responses and mental health teams in schools. And specifically, we heard a lot about Elevate in Adams 12, which came from a mill levy ballot issue and continues to be an important area of collaboration. We also heard about greater coordination and collaboration in the criminal justice system. So looking at ways to divert individuals with behavioral health from jails and co-responder programs, which are leading to increased access to services and that cross-sector partnership and quality, especially for those at high risk. We also heard that stigma is decreasing. This is great news. We see more conversations and resources available, and we see more and more conversations about taking mental health days or self-care, and people reporting a positive push to normalize mental health issues. And we have a number of campaigns that support that, and that the messaging and dissemination strategies that we have traditionally used for some of this stigma reduction messaging is evolving. So really becoming perhaps less global and more targeted to priority populations. We also heard a lot about trauma-informed services. So the idea that services are focusing on the drivers of poor mental health in families and understanding the trauma-related mental health issues. There's current efforts happening to align child maltreatment prevention efforts in Adams County across human services, public health, and early childhood partnerships. And we also heard specifically in the key informant interviews about an effort for mental health providers, deans, and administrators having formal training in trauma-informed care. Oh, I did want to just go back to this quote. So you'll see some of these quotes throughout the slides. These came directly from the interviews. So this idea that it's happening all over. In this slide, we talk about for those who access mental health services. So when people get to the services, they're working. The experience is generally positive. We heard a lot about how well services go for people in terms of high quality treatment and providing essential services through the community mental health centers. We also saw that mental health services can be dependent on insurance coverage, and that those with Medicaid or uninsured may have an easier time accessing and getting benefit from mental health services. And so this is a good lens or focus on the developing safety net of services. And we also saw increased satisfaction of services with a real turning of services towards person-centered care. And again, the focus on trauma-informed service delivery, the co-work between substance use and mental health, as well as increased funding for care from a whole person lens. And then here's some examples that we heard from you all about services that do exist and are thought to be working well for those who access them. So the crisis service came up many times, Safe to Tell, a number of statewide and county public health, public mental health campaigns. We heard about child welfare staff in Arapahoe County, really focusing on mental health strengths when they're doing their work, their clinical work. We heard a lot about social emotional learning, social groups, and life skill resources, especially for those with dual diagnoses or co-occurring developmental disabilities. And then seeing a real increase in response to violence in Arapahoe County, and that community mental health centers are also building capacity around co-occurring issues. So lots to be excited about, and areas that are doing well. And then lastly, we heard there's this growing focus on prevention and upstream approaches, which Monica illustrated so nicely for us, so that we're having more conversations about behavioral health in the context of the population and focused on prevention, and that we are seeing more diverse cross-sector stakeholder engagement with other public health issues. So lining up with chronic disease efforts or other public health issues. So just briefly, this is a really busy slide. I realize you will get all of these after the meeting. So if you want to come back and dive deeper into some of this, you are welcome to do so. But this is specific to the commitment to a community response for suicide prevention, things that are going well. So we see that a variety of partners want to be working outside of their silos and addressing suicide across systems, that we see people modeling about talking about suicide openly and engaging community and addressing it. We see a variety of the community mental health centers really thinking about how suicide prevention has to be the responsibility of more than just the mental health centers, and really working with community to build capacity with trainings. The hospital follow-up program is around and in many, if not most, health systems, and they are working to do that follow-up post-suicide attempt discharge. And we have many health systems implementing zero suicide. We also see a shift in the thinking of law enforcement about how to handle calls related to suicide and triaging folks from entering detention when that's not appropriate. And lastly, just lots of multifaceted efforts across the community. So things like gatekeeper training, education campaigns, assessment and screening, referrals to support resources, care coordination, and resource navigation. And I do just want to pay attention to the chat here. So Sarah, I see your question. Is this based on client feedback or systems feedback? And this is really specific to what the systems and the professionals working in these are telling us. And I think that that's an important layer that we may want to consider kind of folding into the way that we look at these results, to make sure that we're also hearing about that that consumer side of things as well. And then the other question about the challenges, we're going to get there here real quick. So just one last slide here on what's working for crisis services and messaging. So we're seeing quite a lot of good feedback related to how the crisis system is working, focused on the person, accessing the services and what they define as a crisis, and really that no one is turned away, and that the right tools can be offered to manage that crisis. And that we are seeing an increased involvement of target populations and messaging in particular. So of these campaigns that are listed, we have people with lived experience helping to articulate the issues, craft the messages, and do dissemination. So as I promised, we are going to talk about what's not working well. So despite the increasing attention to stigma and that it's getting better, we see that it continues to be an ongoing issue, especially among certain populations. And that, one of the points is that we really need to continue to communicate that mental health issues do affect and impact everyone. We think that COVID and that experience has helped with that, but that it still continues to be something that we hear about from many people in the community about, well, mental health services are for other people, not for me. And so that's an area we need to work on. And also that the way that messages are delivered need to come from trusted sources and not necessarily from those providing mental health services. We also heard that there's a lot of limited awareness of resources. So we heard that there's lots of services, resources in Adams and Arapahoe counties, but the people don't know about them. And that happens both at the individual level, but also at the organizational level. So things are hard to navigate, there's limited capacity, there's limited choice. Some of the outreach methods are not really designed for the people we're trying to reach. And that there's lack of consistent or comprehensive process for assessing and identifying mental health resources. And so it's really exciting to hear, for example, some are speaking about some technology solutions to some of this, but we know that today and right now, these are continued issues. We also heard a lot about limited options. So this perception that outside of the community mental health centers, there's little else offered or accessible. That often when people are able to get a list of providers or services, their insurance might not be accepted, or providers aren't taking new patients, or that the services that are desired or the cultural or linguistic fit is not there. We also heard concerns about people not engaging in services. And what we saw during COVID is really this increased use of teletherapy, which sparked the question of maybe we need to continue that and build on that going forward. We also saw that intake processes can be lengthy and a problem, and also the idea that staff turnover can be challenging. So, forming a therapeutic bond and then having to start all over with somebody, next can be a real challenge. So we heard of timeliness of care as well as perhaps single-minded approaches to treatment. We also heard about eligibility and fit. So things like if it's not diagnosable, you're not eligible. That getting a diagnosis might be a deterrent for folks because they're worried that that's going to follow them throughout their life. That traditional settings may not be the right setting or fit, especially during normal business hours or in a brick and mortar setting. That there's a need for greater variation in the nature of services and how delivered. And that this bottom one is really probably one of the main ones that we heard over and over again, that cultural congruence and our capacity to offer mental health services that fit or align with cultural and linguistic needs are just not there. We heard about cost and funding, not surprisingly, that cost of services can be prohibitive, especially for those with private insurance. That while there's funding for services, there's still a perception that it's not enough. The funding can often drive what services are being delivered and how, rather than what the needs are, and that there is still a fail first model driven by payer requirements. This quote here about affording, the idea that affording mental health services, you either have to have good insurance or you have Medicaid. So anything in between is missing. Transitions of care were another challenge. So thinking about whether it's care between the criminal justice system to a community-based setting or between care settings, lots of challenges in exchanging information, varying formularies for medications, and really needing those community supports to facilitate engagement and follow-up care. And also we heard about turf issues. So politics get in the way around who does what and how the money flows. We heard a fair amount, and we'll talk about this a little bit later in the summit, about, especially related to suicide, that measuring success is really challenging. So it's hard to tell whether anything is working, and especially what is prevented. So if we go back to thinking about those shared risk and protective factors that Monica presented, how do we measure those and really relate it back to the prevention efforts that we're engaging in? That's something we heard a fair amount. We also heard about just a real need for more postvention. And so this happens both at the individual and the organizational level or community level. So really thinking about systems not being equipped to manage postvention, the need to really be able to communicate with public questioning and the media, and that this is a very complicated area that we need more supports and resources around. And then cost of programming, also an issue. And then this is kind of our last laundry list of other gaps and challenges related to suicide prevention in particular. So being reactive, having targeted efforts for specific groups or populations lacking, lack of efforts focused on lethal means, restriction and access. And training has to be ongoing and kind of ever present because of lots of turnover as well as new information. We heard a lot about gaps in information about recovery, as well as the stories of recovery are missing, and that efforts are needed to include a greater focus on building resilience and coping skills. And the last theme that I wanted to just underscore was this idea of equity in mental health and suicide prevention. And so some of these are strengths and some of them are missing, but all of them need to be addressed even further. So thinking about the greater the social need, the greater the inequity. Parity is not being enforced. Really understanding where and among whom the inequities exist and why. Access to the right services. So this underscores some of the points we made earlier. Not everybody has information at their fingertips. That there is an increase in access to mental health services in schools, but we need more variation in that access. We need a removal of all barriers to treatment. We need to see that more people with lived experience have power and are participating in decision making, and that we are listening to people who did not have success, to the question asked earlier in the current behavioral health system. And this idea we heard over and over again that everyone deserves to have access to the right treatments and resources for them. So let's see, I'm just going to go back and look at the chat here before we plow on. I think that there's some great comments in there. And I think that Julissa is probably articulating some pretty interesting points around where this is especially falling down in particular communities. And we can talk about the BHA question later. So very lastly, we did hear that there's a lack of a multi-sector comprehensive group across Adams and Arapahoe counties to do some of this work. So we heard about a lot of great collaborations in each county, but we also heard from folks that these efforts do not seem to be as coordinated or integrated as we might like. And there were a few of those collaborations that were cited. But specifically, we also heard a lot about there's just a lack of shared communication and information between systems. And that, for example, school responses to a crisis always go better when they are coordinated with other agencies in the community. And sometimes that feels very reactive. So after we collected all of this information, we really went to work to build out the frameworks that I'm going to show you later. But we also after did some town hall discussions with many of you. And I just wanted to highlight a few of the findings from those. We'll talk a little bit more about process findings later, but that this is a listing, and we heard this throughout the key informant interviews as well, of the populations in need that we really felt like we needed to have a greater focus on, as well as some of the risk and protective factors that are important to address, and that in some cases we have good efforts going towards, and in other cases really seem to be missing or just need more. So all of that to say that we got a lot of great information from you all, and it's not comprehensive. So we talked to 35 people in depth. We had about 60 people engaged in our town halls. We've done this work over years. We looked at the statewide assessment that HMA did for the development of the Behavioral Health Administration. We also looked at an assessment that was done in Douglas County for some of the work that they've been doing. And it's still not each and everything. And so later today, we're going to hone in on some of the areas that we think are probably most important and ready for us to be able to do some collective work together around. Yes, Molly, absolutely. Many of these themes came up. So discussion of peer supports and programs. Workforce is a huge issue. And I think we're bundled under some of those broader categories of lack of services available that, addressed fit or choice. And the payment reforms we did hear about, although we're not going to spend a lot of time on that because I think that's certainly happening, and those discussions are happening at other levels and layers. So let's move to an activity. I'm tired of talking for a moment, and we'd love to get you all to just start thinking. So I'm going to hand things over to Patty. She's going to show us Jamboard. I hope that most of you are familiar with this, this tool. It's an area where we can all contribute thoughts and ideas. And what we'd really like for you to do is take a look at the participant list. And let us know who you think are missing. And it looks like we already have one on the board there, which is awesome. So who is missing from this conversation today, and that we need to do some more outreach to? And then on the second page, we're going to ask you about ideas for the engagement strategies for people with lived experience. So Patty, I'm going to turn it over to you to just give us a quick demo.
Okay, great. Can everybody hear me okay? Okay. If you haven't used the Jamboard before, I'll show you how it works. At the top where I just clicked, it shows you which page we're on. So right now we're doing these first two. And to do a sticky, you just grab this icon here and click on it, write your text, and you can change colors if you want. And when you hit save, it'll go to the screen and you can move it around and resize it. It leaves the sticky note up. If you're done, just hit cancel. And then if you want to do another one after you hit cancel, just click it again. You can do as many stickies as you want, but we don't need duplicates. So if someone else has put your idea down, you can leave it at that. And if you have problems using the stickies, put your answers in the chat and we'll add them to the Jamboard for you. When you are done with the first 2 pages, which is partners and strategies, go ahead and start your break. It'll be about 10 minutes and we'll put up on the screen the time that we'll reconvene.
Thanks, Patty. And I'm just seeing who Lisa. So we're going to leave this Jamboard open throughout the rest of the session. So if you need to step away and start that break, go ahead. We will, you can participate throughout the day here. And again, if you have any questions, just let us know. Yeah, we've got a lot of great thoughts here. One of the things that I will just mention is that just because people are not here today doesn't mean that they haven't been involved or that they are not on our list. So obviously availability for a 3-hour chunk of time, a couple of days, is a challenge, but definitely want to make sure that we're really hearing from you all about how we increase not only the list, but the participation among many of these populations or our partners. Yes, Molly, thank you. If you're on the phone or having any other technical barriers, please go ahead and put in the chat, or you can even speak up and we can type them out for you if you'd like. And Molly, the questions, so the first page are what partners are missing. And the second page, thank you, Patty, are engagement strategies for people with lived experience to be involved in this group and this work. Okay, thank you all. Please keep adding as you like. I think I'm going to go ahead and call the beginning of our break now, though, as well. So we'd like to take a 10-minute break. encourage you to please get up, get your coffee or your tea, stretch your body, do whatever you need to do to come back ready again to engage. And let's see, Patty, I think you were going to put a reminder slide up for us with the end time. So if we have a 10-minute break, we'll be coming back at 10:35. I opened too many things on my desktop during the break here. All right. Okay, so we're going to jump into this next section. And really the intent is to do a brief overview of the frameworks that were really built collaboratively with many of you. And then we're going to do a brief overview of those top issues of things that need to be changed. So we'll come back to those and look at them and how they sort of line up across the mental health continuum. And then we'll wrap up the day with some work around collective impact. So Monica this morning did such a beautiful job demonstrating some of the shared risk and protective factors across the social ecological model. So I'm not going to spend much time on that today, other than to reiterate that this is certainly a complex area. There's many different layers to our work in promoting positive mental health and well-being and preventing suicide. And so it's really going to require us to develop and implement many different strategies and explore opportunities that acknowledge this complex combination of events and conditions. And so while we, like I was saying before, we captured a lot of the issues that need to be addressed, we didn't get them all. We didn't get everybody's perspective. And we want to continue to collect and understand those issues so that we can really think about some ways to apply our collective power and influence to make some changes at the local level. I also wanted to just include this. Hopefully many of you have seen this framework already. So this is the framework for the Tri-County Overdose Prevention Partnership, which has been a collective group that's been really working together for a number of years. Tri-County facilitates the group, but does not own the group by any means. And we wanted to share this with really the intent and the acknowledgement that there's lots of work in behavioral health that is focused on on substance use. And we're not really scratching the surface of much of that in our work around mental health and suicide prevention. Obviously, they do not occur in silos, but we do want to make sure that we're thinking across that continuum of behavioral health in terms of areas that we have opportunity to build or fill some gaps, and that there are other groups that are meeting and very active that are addressing certain issues, and we have no desire or interest in duplicating that. So if you have questions about the Tri-County Overdose Prevention Partnership, separate from this meeting, please let us know and we'd be happy to get back with you around that. But you'll see some themes in terms of the way that that group has also laid out their framework for strategies at the local level for opioid prevention work in particular. And you'll notice that they have some of the same values that we're going to be talking about here soon too. Okay, so from all of that assessment work and many conversations with you all, with the support of a really robust advisory committee, we were able to develop mental health and suicide prevention frameworks. They're similar and complementary, but differ in a few ways, which I'll articulate here soon. And these are really designed to be a catalyst for implementation, so that as we bring cross-sector groups together like this, that we have some structure and guidance to focus our work around. And they're really meant to provide that clarification about the ways that we do this work, and some of those guiding principles and values, and evidence-based or research-informed strategies. And so we'll go through these. Hopefully many of you have seen these before. But before I show them, I do just want to mention that our goals for these frameworks were to create choice, support that continuity of care across the continuum, really think about collaborations that exist, and look for ways to unite or knit some of those together into a cross-sector and cross-system effort. That we always want to be thinking about how we focus and frame and educate on the social determinants of mental health, how we use this to refine and change language and action about mental health and shared risk and protective factors. And really, to the point of what we were looking at the Jamboards, think about engagement for those with lived experience, and hopefully really bring them into our decision making and implementation. And I do want to note that we have a few people here today who have lived experience, but we certainly have lots more to do there. Okay, so this is the mental health framework. And again, I hope that folks have seen this before. We'll go through the sections here quickly. We can drop the link in the chat for this document if you would like to save it or print it out for yourself. If you want a printed copy, you can reach out to me. I can get some to you. But this is really the framework that we hope to be using to help guide some of our discussions and efforts going forward. So really starting off, we've spent a lot of time thinking about the guiding principles, or what we call the North Star for this framework. And you can see that those are rooted in equity, social and institutional equity, that we want our work to always be rooted in research-based approaches, that we are looking for community-driven solutions and that we support those, and that we don't do this work alone or in silos, that this really requires that partnership aspect across sectors. How the work is done, so that's our next layer here. We have data always front and center, really recognizing that it's our responsibility to collect and report that data and use it to inform our decisions. I will say that we will be taking a deeper dive into data on day 2 of the summit next Monday. We'll have some folks from our epidemiology department coming to share some of those more detailed data. We want to have an action plan, and so this is what holds us all accountable to know what we're doing and to do what we think we're going to do in a way that is structured, and that we have sustainability in mind, and resources and leadership all available to make this work successful. The next layer, our orange layer, are about our values. So this is really the fundamental beliefs of all of our partners and us together to ensure that this work is person and family centered. So really the idea that any person's potential and ability to make choices need to be front and center, and that people operate in the context of families. And so that's also very important as we think about that person-centered approach, that we have a whole person, whole community perspective. And this really gets to that application of the upstream approach that we spoke about earlier and those social determinants of health, and that the work that we do is trauma-informed. We also really spent a fair amount of time trying to think about what our outcomes should be. And these are broad and very overarching. And the framework that we really leaned heavily on actually came from a framework that the First Nations of Canada had put together for mental health in their communities. And it's really rooted in this idea of hope and belonging and purpose and meaning. So if we're successful in the work that we do together in our communities, we will be increasing these outcomes towards that mentally healthy, suicide-free community. We also articulated the mental health continuum. And so this is, if you're looking at the full framework, the boxes on the left side of the document. And so we articulate mental health and wellness promotion, which are strategies that are really designed to optimize mental health and promote well-being. This is where a lot of the determinants of mental health work shows forward, and those environments and relationships that support our well-being. Prevention, pretty straightforward, but these are strategies that help us to prevent and reduce the incidence of mental health, substance use, and suicide behaviors and those associated negative health outcomes. And this again is an area where we really focus on the mitigation of risk factors and increasing protective factors. Clinical and support services. So this is where access and engagement and services for people who have a need, whether it's a concern or a diagnosis and ongoing treatment. This is the realm where that work happens. And then we have 2 categories of strategies for recovery and reclamation in the mental health framework. And then we speak about recovery and postvention in the suicide prevention framework. And so these are strategies that are really meant to focus on ways for individuals to thrive in a community, to support recovery, and to address both individuals and communities in the response to a suicide or suicide attempt. So I'm not going to go through these in super clear detail, but just wanted to highlight that for each of these areas of the continuum, we've highlighted some key strategies. This is not a comprehensive list of all strategies, but certainly wanted to put forward some of the key areas that we can do work, and that these strategies can then be refined and adopted according to local need. So for mental health and wellness, We're looking at a concept of health in all policies, the determinants of mental health. We're looking at social cohesion and community connectedness at a variety of levels. And one of the strategies that we put forward here has to do with organizational and employer practices and policies. Here's just an example of some of the applications of the strategy across the life course. So this is an area that we want to make sure that we're thinking across the population at varying stages of need as well as opportunity. And these can be, again, built upon, added to, and tailored for local need. Here's the prevention strategies. So we're working on this first strategy today in terms of fostering networks for collective impact, really thinking about our communication and education programs, and then really addressing and mitigating some of those risk factors and strengthening many of the protective factors and building strengths and knowledge to support those. Again, here's across the life course. Again, not a comprehensive list, but some ideas to get us started. Some key strategies in the clinical and support services. So thinking about screening and early identification, integration of behavioral health care, care coordination, patient navigation, and quality referrals. And this is a great place to acknowledge that cultural relevance of services. And so here's some, again, ideas of ways to apply this across the life course. I will say that some of the thoughts that came forward earlier in our discussion, I think articulate some of the work that you all are thinking about in this area. And then for the mental health framework, here's the recovery and reclamation piece of thinking about peer support specialists, thinking about education campaigns, and this idea that this is not a linear experience or process to live with recovery and reclaiming quality of life. And again, here's some ideas across the life course. As I mentioned before, we have a complementary suicide prevention continuum. So all of those layers that I went through, the guiding principles, how the work is done, and the core values are the same. And the continuum remains the same, although we did articulate a little bit of a distinction in terms of postvention and recovery. And so same layout, but slightly different strategies. So here in the prevention area, talk about access to lethal means, thinking about programs that really support resilience and connection, and multiple settings to really support identification and risks. And the same format, we go across the life course with some ideas. Some of these things are already in place, but may need to grow or be refined. Others might be places for us to apply in different environments or with different partners, and others may need to be addressed newly. Here's some of the resources, or strategies of the clinical and support services. We talked about zero suicide earlier. Follow-up, I think, also goes here. Really thinking about prevention of reattempts, thinking about the specific interventions for suicidality, as well as outside of the clinical setting, ensuring that the clinicians and other professionals have skills and information and quality referrals. And again, the cultural relevance piece. Here we have more across the life course. And lastly, our postvention and recovery elements. So thinking about coordinated responses, both for the individual and at the community level in the aftermath of a suicide death, as well as education and advocacy for the way that we speak about deaths or suicidality. And then really thinking about policies and procedures across systems to support folks coming back to their systems. And again, lastly, here's our across the life course piece. So I'm going to pause here real quick. Okay, Lindsay, I see your question. And this is a great question. I think we'll dive into the hows a little bit later. There is some research and evidence based to support lethal means access. But for our communities, that's probably one of the tasks that we may want to focus in on if that's an area that we choose to prioritize in terms of how we do that. So great question. Okay, and so you've seen all of these before, but I wanted to put them in this format to show that these are not discrete siloed areas of work. They connect, they flow from one to another. They are not linear and often very cyclical, and that they really should be thought of as a true continuum. And what I wanted to do here is articulate at least some of the categories of the things that we heard earlier through the assessments and the analysis and our town halls and our conversations with you. So these are categories that I identified from that assessment. We can change them, we can update them, we can add more. But I wanted to at least start to lay them out as we think about them across the continuum, to say, here's where some of these areas of opportunity and work might show up, and where we might want to be thinking about applying some of our energies. And so I definitely wanted to make sure that we didn't forget the stigma reduction work, the prevention of suicides, as well as the risk factors that may lead towards suicidality. This idea of resources and the awareness about them, especially at the local level, seems to be an important area that we might want to focus on. The options and fit can kind of come together into a category, transitions of care, postvention, and I actually put stigma reduction on here twice because I think that this is one of those areas where it probably needs to circle all the way around and through the continuum. So I want to pause here and just see if there are others that let you kind of sink in and see if, one, if you're looking at these categories, is there something as a broad category or issue that we might want to consider working on that's missing from these blue boxes? Or did I capture sort of the things that we talked about in a way that might need to be refined? So I'm really looking for some feedback on whether we captured all of that assessment piece here in a way that helps us to at least organize some of our thinking and our action together. And so I can pause right now and just see if anybody wants to chime in and ask any questions or suggest another category. And if we feel like we're good, at least with these as a starting point, then we can move into an activity that we have back on Jamboard. Any immediate questions or concerns or additions here? Okay. All right. So Patty has our Jamboard link back in the chat. We'd like to redirect you there. And so what we'd like to do is take those categories, those 3 to 5 issues across, the 6 issues across the continuum, and we'd like to prioritize those. And some of the questions that we would like for you to ask of yourself and of each other for each of these areas is, do we have action that could be leveraged right now or in the near future to begin work on this? Is there political or community will that can be leveraged? And is there funding that can be leveraged? So I'm going to stop sharing my screen. Patty, if you want to show the Jamboard, I think that might be helpful to show people what we're speaking about here. So if you go to the 3rd page, yep, and so Patty's pointing to where you can go to the different frames. So then, yes, so we have the continuum across the top, and then we have the 6 categories that we pulled from the assessments and your feedback. And what we'd like for you to do is to consider these questions. So we have 3 different pages that look about the same, but here we have actions to leverage on page 3. We have political or community will on page 4. And this funding question on page 5. And so I'd like for you all to think about opportunities, resources, needs to answer some of these questions, and start to let us know if you see any of those that could fit in one of these 6 categories. And so we can take a few minutes to let you think. You know, if we were all together in one big room, you'd all be milling around with sticky notes, putting them up on the walls. So I appreciate you bearing with us in the virtual world here, but really just want to better understand your thoughts about where we might have traction to begin work together, or where there's already work that we can build on. So again, thinking about actions to leverage, political or community will to begin work, and funding to leverage. Oh, yeah. So Wendy asks a great question. So can I share more on where some of the framework strategies fit into these categories? So I think that as we went through, we tried to kind of post these across the continuum. So if you think about the wellness and promotion strategies, they, you know, they'll often line up here in the stigma reduction area, but they might not fit there, and that's okay, because we may have other strategies that we want to articulate there. So you can put them just, yep, just like you know, somebody may have put, you can put them up top in the colored areas. So we think that obviously suicide prevention might fit. And if others have ideas or examples, definitely let me know where you think about that. Yeah, and Hulisa, we are really excited to see that the state has a postvention group. And I guess what I would challenge this group to think about is ways that we can elevate and or utilize some of that work at the state level and apply it to our local needs in Adams and Arapahoe counties. I wanted to call attention to a comment that Monica put in the chat, since folks are busy writing sticky notes and things. But Monica, do you want to read this aloud, or let us know your thinking around this question?
Sure. You know, I've been struggling with the notion of how much do we lead or move as a community, knowing that there are state efforts also happening. And I'm just wondering if it's possible for us to use our community energy to move things along and then adjust as necessary as the state advances, especially when we have leaders in our communities who are involved in that work. And I'm wondering if it's possible to do both simultaneously so that we do keep moving and we can inform the state work as well.
I think that's an excellent point and a great question. What do others think about that?
Hi, Emma. This is Wendy Nading, a nurse manager at Tri-County Health Department. And I completely agree with what Monica's saying. I think a lot of the statewide behavioral health work will take a long time, and we need immediate action in this area. And I think that there's just going to be such broad infrastructure change that whatever community partners come together to do now we can parallel and align with how that fits in the statewide structure as those big decisions and infrastructure changes happen down the road. So I really appreciate Monica's comment and think that, you know, sort of waiting to align as that work happens, we might be waiting a while. So where there's will here to get started, and then just closely following that work and reporting out on that work and identifying those opportunities for alignment rather than trying to do that work now. I just would support that as well. I think that's a really good point.
I also just want to jump in and say I really appreciate just this summit in itself, because I feel like school districts have felt so much burden around suicide prevention for youth and you know, really the postvention piece, and it feels really nice to have other partners who are saying, hey, this is a community issue, let's work on this together. And so you know, a lot of school districts, and I think the ones on this call today, have been doing a ton of things to kind of expand all the way up to creating our own kind of networks of care because of access issues and foundations funding services. So I think there's just a huge burden that it feels on schools as this kind of community hub. And so whatever we can do to work together and look at these system issues, I think it would be awesome to look at them at a local level and not just wait for the state. But there's a lot of great work happening, and I think if we can just keep building on that, it would be really helpful. But I just want to say thank you, and we also I'll put in the chat, we just had a 2-year pretty intensive research project from Dr. Anna Muller and her team, which we'd love to share as well, which is more specific to just kind of what schools can do. So I'll share that too.
Thanks, Nate. Yes, I was able to attend her presentation of that report. I think it's a great example of that local data collection, as well as real analysis of what's working and where support needs really are happening. And I would definitely encourage us to keep thinking about, you know, not just the weaknesses of the systems or the challenges that we've been talking about, but also ways to strengthen the areas that are going okay, or that we're doing good work in, and also thinking about being allies in that work for folks like schools who may feel like they're shouldering a heavier burden. I see Molly's question in this chat about what about gun violence and gangs as a piece of suicide? And I think this is a great question. I know that there are folks on the meeting today that have been involved in some of the youth violence prevention work in Aurora and in other places. Does anybody want to speak to that?
I can just speak up and say that we have, at least from the substance use prevention angle, been working very closely with the Aurora Youth Violence Prevention Program and plan to continue that. Our goal, we also have a small grant to be doing youth substance use prevention in Aurora. And so we're working kind of side by side, hand in hand with the violence prevention program to really try to make it a fully collaborative, collective impact, impacting both I should say all outcomes. So our deliverable to our funder of substance use, and then the program deliverable to their funder, the city, around violence, but then also, we know that also impacts suicide and mental health as well. So, we're happy to think about how some of the violence work plays into this as well. I think it's a really important point that you brought up. Thank you, Molly.
Yeah, and I can say that I've had several conversations with Christina, who leads that effort in Aurora, and others, about how often mental health and suicide work does come up in those conversations about violence prevention, and how, again, I think that the work that we may do that's really focused on mental health can be complementary and intertwined with some of these other efforts. That they're obviously, if we're thinking about this person-centered and whole person, whole community lens, that these are happening within the same people, within the same communities, and that we need to be coordinated in our efforts to address all. So I'm scrolling through the Jamboard, and it looks like we are just having all kinds of wonderful ideas and thoughts. I see that our funding page is a little leaner, and that may be indicative of the funding opportunities, or it may just be that folks are really honing in a lot on the first two pages. So just wanted to make sure that we are taking time to answer all three of the questions where possible. I love that somebody figured out how to use the pen to star somebody else's sticky note on community and political will. I wanted to go back in the chat. I feel like I'm not doing a great job of staying up on it in real time. Dr. Douglas had a comment in there about how we should also be thinking about opportunities to encourage implementation of state policy change that hasn't happened, or that, the policy changes happened, but it hasn't been accomplished in reality. Dr. Douglas, do you want to say any more about that?
Yes, just picking up on Monica's point about where to focus effort. I do think that there are, times, and maybe under the BHA's effort, those will be fewer, but I think parity is a great example where things have happened and it's being incompletely implemented, and understanding where that incomplete implementation is happening, and working with elected state legislators is a local activity. And if we've got, or with branches of state governments, I just want to call that out because a lot of effort is going to the parity issue. And the fact that it's lagging, I think, is frustrating to many of us.
Thank you. And, as I reflect on that idea, it occurs to me that we don't necessarily have policy activities and advocacy really showing up across the continuum in our key strategies. And I think that might be a bit of an oversight in our framework, that's perhaps something that goes more through as how we do this work across all aspects of the continuum. Okay, I want to check in with the group. It looks like sticky notes are slowing down. Do we want more time to keep working on this activity, or are we ready to kind of review together and move on? Always saying that the Jamboard is open. You can always add to it on your own. How do folks feel? Do we look like we're ready to kind of summarize a little bit? This is the part that's hard when we're not all together in a room. Let's see where the buzz is going. Okay, well, let's go ahead and do that so that we can kind of keep moving in our work. So yeah, Patty, if you want to go back to page 3, maybe we can just kind of take a look at some of these, give folks a few minutes to read others' comments. It looks, and I can kind of go through each of the topic areas and just call out a few of the themes that I'm seeing. So if we start under mental health and wellness promotion, looking at stigma reduction, we have several media campaigns that are cited. Oh yeah, Molly, absolutely happy to read some of these. So we have things like Below the Surface and the Let's Talk campaign. Somebody mentioned the pilot for Let's Talk that is happening. This is being done, for those who aren't aware, through the Metro Denver Partnership for Health. That behavioral health work group has launched or is supporting a pilot that really comes through funding that Centura has helped secure, that is looking at getting both feedback on messaging of Let's Talk, as well as message dissemination tactics for Let's Talk Colorado, specific for people of color. So our Black populations, as well as our Latinx populations, where we had some assessments that really showed us we weren't reaching very well with that campaign. And so we've been able to engage with some community-based organizations really dig into those questions about what needs to change for the messaging and how can we better disseminate. So that's a great example. Looks like we also have some themes around training, really having some of the awareness of stigma and the issues becoming truly normalized. Really thinking about community gatherings for groups that are underutilized, but yeah, underutilizers of mental health services. I've been talking too much this morning, obviously. And then again, really thinking about these upstream efforts. In the suicide prevention column, we have bulk up second wind funding, provide trainers for gatekeeper programs, more resources for faith-based organizations, better screening for risk of suicide, newer laws regarding gun locks, community needs youth intervention programs, focused on safe space and trusted adults. So lots of great actions there. Resource awareness. So I think the idea of, in light of state care coordination infrastructure, what is the local and regional resource directory role? Trainings again, ambassador program again, thinking about, again, more community mental health based program providers, especially in immigrant communities. Lots in the clinical and support service areas. And so it looks like we have a lot of momentum around various interventions. One that's jumping out is bringing the STAR program or other mobile response programs to Adams County. I don't know if we have anybody from the Aurora mobile response team on board, but if anybody wants to talk a little bit more about what that example is. Courtney, do you want to chime in and just let us know about the Aurora efforts?
Absolutely. So we are in our pilot phase right now. We end our pilot phase in March of 2022. So coming up in the next few weeks, we implement a paramedic co-responder approach. So similar to the STAR program, we utilize a paramedic. We do work with Falk Rocky Mountain, and we deploy a licensed mental health professional from the Aurora Mental Health Center. They are responding to 911 and non-emergency line calls solely. So we're not taking anything from a back line or a community line just yet, but we are looking into the possibility of that, just because we do know that there is some trauma associated with calling 911 just as much as there is with working with law enforcement as well. So far, we've really prioritized our public safety partner relationships because that gives us the ability to actually take those 911 calls away from them. We had to build a lot of trust with our dispatching systems and with our fire, police, and other paramedic agencies. So far, it's been really successful. We've seen about $60,000 in cost savings just from diversion from emergency departments as well as jails. We do a lot of community outreach. We work a lot within the schools. We try and prioritize this response within the schools due to, just the school to prison pipeline that we see and all of the research surrounding that. So we've had a lot of luck so far. The team's gone on approximately 200 calls in a 4 or 5 month period, and we're hoping for more. We're hoping to expand. We're going to have a full program evaluation done. We are presenting to our council in the next few weeks with some expansion options just to see where we end up.
Thanks, Courtney. That's great. And it's been really excited to see the progress and how quickly this program is scaling up. And so we'll definitely look forward to more updates on that. I would say that this is one of probably many examples where this type of network can really support some of that shared learning across programs, both in terms of how they're working, but also how to bring them up and bring them forward into reality if they're missing. Okay, so I want to come back and just try to summarize a few more of these elements. So I see a lot about workforce. and really kind of across the continuum of workforce in access options and fit areas. So a lot about cultural competence and thinking about accountability for language access and sort of these alternative care delivery models. And transitions of care, it looks like there's some, really good opportunities to think about in terms of, working with RAIs between hospital systems and school districts, thinking through some of the discharge kind of logistics and communication barriers. Peer supports are great there. And then in postvention, really thinking about some opportunities in supporting schools and having more of a community based forum and support practices and caring for caregivers. I think if we go to the next page, thanks, Patty. We have this political will. It does look like we have a number of areas where there's political and community will. So thinking about schools, ongoing support for campaigns, storytelling from leaders, I think could be really powerful. I love this recognition that some of our recent experiences with the pandemic have really pushed mental health to the spotlight. So let's not squander that opportunity. Again, in looking across some of these systems, there seems to be a lot of interest in co-responder models, safe storage laws, funding and policy support for trauma-informed support, and the equity piece, really, really important. Looking at supports outside of office walls, non-clinical solutions, the SHE, so this is the, does somebody, I'm gonna get the acronym wrong, who can tell us what the SHE acronym is? I know there's a number of people much more expert in this than I am. Social health information exchange, thank you. I always get stuck on acronyms. Okay, so a number of technology platforms that are being referenced in resource awareness. Access options and fit. Looks like there's definitely some momentum to looking at Medicaid payment, looking at administrative burden, transitions of care. Definitely a lot of opportunity for care of minors. Yeah, this question about system overload, I think is a great one. And then in postvention, definitely bolstering some of these areas of support, especially for those who are less, have not yet had to navigate through some of these challenges. So definitely there. And then let's look at page 5, and then we'll go on to our next activity. So good. Okay, looking at funding to leverage. So we think about the State Bill 137 as well as State American Recovery Act funds. Those are all definitely coming down. We have lots of money coming into the state as well as through our state legislature. And so there's probably a role for some advocacy around some of the local solutions that we're talking about here. Looking at supporting youth outside of school pieces, some potential RAI funding. Okay, and some of these are continuing across. Absolutely. Okay, well, thank you all for taking time. I know it can be a little challenging to read through all of the sticky notes, but I think that was really helpful for us to get a bit of a sense of where we have energy as well as opportunities to leverage resources. So, so having had all of that to kind of chew on for a few moments, what we'd like to do is ask you all to complete a poll. And so this is meant to really help us hone in on our top 3 priorities out of those that we've discussed today, with the intent that we would be able to provide some infrastructure to get to work on some of these ideas. So Patty has created a poll through Zoom that's going to pop up. And Patty, I don't know if you want to give any instructions about how to do this, but essentially we have our 6 topic areas that we've put forward from the assessments, and you can rank them.
Yeah, I couldn't take the poll since I created it. So I think you put a number 1 through 5 according to 1 being the most important and 5 being the least out of the list.
Okay, and I think we have
it's actually 1 through 6.
1 through 6, yeah.
Yeah.
Thanks.
So 6 is being the most that you want?
1 is the highest.
Ah, okay.
Okay.
And can you guys tell me where is the poll?
It should be popped up on the screen.
Let me see. Okay, got it.
Great.
This is Wendy. Do you know, I accidentally selected 2 for one of the numbers and it's not letting me deselect. Does anyone know if there's a way to do that?
Yeah, it will allow you to reuse the same number. So just go up to the next number for your next thing.
Okay.
Okay, and I see John has what we mean by options and fit. So going back to the assessments, this was sort of a catch-all area for the understanding that we have limitations in options for services, both in terms of where they're provided as well as how they're provided. And then fit is really kind of a broad term for eligibility, cultural relevance, sort of that this is the right service for the need that is being presented, as well as maybe linguistic and other barrier accommodations. And so we'll continue to give this a few moments. What I can see in the results is that we have 23 responses and there's 40 participants on here. So we'll give it another few moments and let folks do their prioritization. Patty, I'm going to ask you a question. Sorry, I don't mean to confuse anybody else. So it says we have 36 total. Does that mean that those of us who are hosts are taken out of the total?
Yeah, I'm sure that's part of it.
Okay. All right. Oh, yeah, Jesse's saying she can't participate. Okay. All right, well, we have just a handful left of people. I'm going to say 30 seconds and then we're going to close the poll. So if you've stepped away and want to get your answers in, please do so here quickly. Okay, I think we're ready to end the poll. I'm not seeing any more movement on it. And so Patty, are you able to share that?
Oh, can you not see it?
Can people, I'm not sure if I'm seeing what everybody else is. Are you all able to see the results?
Yes.
Oh, great.
Awesome. Okay. Great. So it looks like we have, some pretty strong endorsement of almost all of these areas. So we want to do them all, which is great. I think all respondents endorse suicide prevention. We have 97% endorsing stigma reduction. We have equal numbers around resource awareness, options, and fit, and then fewer responses around transitions of care and postvention. And so I really hoped that we might be able to drill these down to just about 3 groups that we can do going forward. I think it's clear that we will have a suicide prevention group. I think that we will have a group around stigma reduction. And I wonder if we can create more of a access bucket and still kind of fold in both the resource awareness and the options and fit pieces. How does that sound to this group? Does that seem like a reasonable area to kind of bring those ideas together? We'll obviously have to do some prioritization within that grouping. But if we were to say that we are walking out of here with a suicide prevention category, a stigma reduction category, and an access category, I see a thumbs up. And it's not to say that we wouldn't, address the other areas of work, but we might not get to them first and foremost. Molly, I see your hand up. Did you have a comment?
I did. I'm sorry. I just am doing the usual caution that's obligated on the side of the package. If we throw everything on the list and try to do everything, we're not going to succeed at anything. So if we can add a timeline, which we were just beginning to mention, around priorities, then we can show some success and build energy for the rest of the work. But the categories are fine. I just want within that a sense of sort of this month, next month.
Yep.
Yeah. Thanks.
That's a great point, and I appreciate that. That's a comment that comes from a lot of lived experience, Molly, I'm sure, and many of us share that.
And this is Julissa. Being an attempt survivor, I feel that 3 priorities is going to be a whole lot for all of us. Just addressing suicide prevention is going to take, and I'm with Molly. I don't know if we need to focus on 1 or 2 maximum, but 3, it's a whole lot. It's a whole lot when you're getting into a field that I don't even understand, and I was part of it. So I feel that if you guys have not had these experiences, have not been around it, it's easy to be, oh, we can do A, B, C, and D. But me, that I have been part of this world and still having a hard time understanding how is it that we can integrate this with policy, community, I think, guys, it's too ambitious. I know you guys rock. I know that, but I don't think we rock that way.
Thank you, Lisa. What do others think about that?
Emma, this is Wendy. I actually think 3 and 4 are naturally going to be included in 1 and 2, or even 1 or 2. I think you can't really talk about stigma reduction if part of the messaging isn't how to get help, which then means, awareness of where to go for help. So I think one way to minimize it might be to know that the strategies under 1 or 2 areas are going to include some of those priorities that are falling at 3, 4, 5, and even 6.
Mm-hmm.
So maybe I land on however many and just know that these other categories need to be part of the strategy development to make it a little bit more manageable. And I would agree too. That's a lot to take on.
Yeah. Patty, could we relaunch this poll and ask people to only rank their top 3, or maybe that wouldn't work. I'm trying to think on the spot here, but I just want to give us an opportunity to kind of take in some of this feedback and reassess our prioritization. And maybe the poll's not going to serve us for that. How do others think about bundling up some of these as strategies into 2 larger categories of suicide prevention and stigma reduction? I see, Nate, your comment about access and transitions really being the area where you all are struggling. Mm-hmm.
Yeah, and I'll just say on that, I know this is a broad group, so it shouldn't be just around schools, but I do think you can go around and around in circles for years just doing prevention and stigma campaigns and all of those things. But where we're really, really struggling is getting kids access to care, kids going into hospital and not having good transitions, and us even knowing when kids come out of hospitalization or those kind of things. So it's just a thought. I don't know if other school districts are at the exact same place, but that's really what our big issue is right now.
Mm-hmm.
And Nate, I think you're just on point when we have, Latinos have the highest rates of suicidal, and then when they go to the hospital, right? What's next after that? When I got released from the hospital, I remember feeling lost. So it's the postvention too that goes with access to care and care itself. So I think the top bottoms go with the top bottom priorities, or whatever we want to call them, go with postvention. That's what postvention means. Is like we don't let them go. We still work with them. We teach them how to act, or we help them navigate those systems that they're so difficult to navigate, especially when you get out of the hospital and you feel lost and you feel empty and you feel like everybody's putting shame on you. So we're here to help you with postvention. So that's why I'm very passionate about postvention, because I know how it feels when you get out of the hospital and no one is there for you because you did something wrong.
Thank you for sharing that, Lisa. Okay, going here to a few other comments. Stigma reduction and suicide prevention also seem to work together. I think part of what we're bumping up against here is that these are all interrelated, right? It's kind of arbitrary to put a hat or a box around any of this work. And to Jennifer's comment about creating that that network and really thinking about how we connect all of these pieces is really, really important. So yeah, I think in some ways we're just going to have to you know, be okay with the you know, the ambiguity of the discussion. And then I think I wanted to reiterate Mara's point too, about 3 being too much if the partnership is too small or if things are not happening. So Patty says she has another poll that we can do that asks if we want the top 3, that we could rank the top 3 and if that might help us kind of parse these down, and that might, or we might just get split results again. I think an alternate proposal might be to say that we agree that we're going to have 2 groupings, perhaps one that is around suicide prevention and another that is focused on sort of the service network as well as stigma, and that we spend time on next Monday to hone in on the particular strategies and the actual agenda that we want to be endorsing for all of us to come together. So I guess that's my proposal going forward is, can we say that we are going to select 2 groupings and that we can spend some time next Monday really, you know, figuring out what, you know, what our specific actions are going to be, and go from there. Because I think what the original poll told us is that all of this is really important. Do we have any blocking concerns about going forward with 2 groups, one suicide prevention and another that, excuse me, that will have a magic naming for mental health access and stigma? All right, I think let's go ahead and do that. And we,
so it's Molly, sorry. I don't want to lose what Nate was saying about where we're stuck is with access and fit. So I'm just following your magic naming thing here. Is that concept included in the second bucket that you described?
Yeah, I think that's a necessity, especially based on, you know, where we really saw traction around that today.
It's just where the system is stuck, where kids are stuck, where families are stuck. I mean, bless Julissa, we can't get to postvention until we get people in the right place. So I just don't think we can ignore what Nate was saying.
Thank you. Sarah, I see your hand up.
Yeah, can you hear me okay?
We can.
So I work in primary care, and we run into the same issue that the school districts run into, where it's really, we really struggle with getting these, with getting our patients access to mental health or behavioral health services. And I agree. I mean, I didn't put it as like a top priority, but I mean, we also have the transitions issue. I put it on the jam board too, of oftentimes we get from the M1 holds, we get those clients discharged to us in primary care, but we're honestly not the best place to be for these clients to be discharged to, because they need a higher level of behavioral health services than what we can offer. But so I just wanted to say, I think we have a parallel process in primary care that they're having in the schools.
Thank you. Jennifer, I see your hand up.
Yeah, hi. This is more of a question. I'm kind of new to the conversation, but not new to the topic. I'm just wondering if there is another, is there a community of learning or a consortium of that's similar to this, where people and organizations are coming together on a regular basis to kind of network and learn? And I ask this because I'm on a group called Food in Communities, which is, working with alleviating hunger and addressing food issues in the community. And I've just found it an incredibly useful forum to get to know other people who are struggling with these issues, and the networking has just been incredible. So I would just suggest, if that doesn't exist, maybe that's something that this group could form into.
Yeah, thank you for feedback. And I will say that there are existing groups, and they're often kind of fragmented. I think that was a big part of what we heard, and we'll jump into that a little bit more on Monday. And so I think it's a great question and a great idea for us to carry forward when we think about the composition of this network, both in terms of how we focus shared work and also create learning opportunities. Courtney?
So I put this in the chat, but I want to emphasize how important education is to providers themselves. Something I see a lot in the crisis intervention realm, specifically within the mobile crisis intervention realm, is a lot of providers feel uncomfortable doing safety planning and preventing mental health holds from the get-go, which, if we're just jumping straight to a mental health hold, we're creating so much mistrust within the community of mental health providers. And we also see that someone's risk of suicide is so much higher after a mental health hold within those following weeks. So something that I personally would like to see from this group is education to providers on safety planning and means restrictions. The stigma lies within the professionals most of the time, because people hear suicide and they panic and they write a hold or they call the police. So personally, for me, within this group and within this effort, I would really like to see education to providers.
Yeah, thank you. Okay, so I want to do a time check here. I think that we can do some work behind the scenes to try to find our second grouping and think about the naming of that, because I think what we got today from you all, and I just really appreciate your willingness to wrestle with this a little bit, is that, whatever our large umbrella topic is, that we have several layers to address and that we're going to need to prioritize those within them. And so I think we can set up the way that we do our meeting next part of the summit to really help us parse those priority areas apart, and to set some early agenda items that we agree to work on, and still also capture the many other areas that perhaps need work that we might not start right off on. But I think we do have some good feedback from you all and some momentum behind ways that we can organize that work. And I'd love to be able to bring that back forward to you all next Monday. And we have some activities to help us do that refinement. So in the last 5 minutes, if you all are okay to take a pause here, I'd like to hand things over to Heather Baumgartner. She offered to give us some closing notes and help us tie this session up at least as much as we can to get us thinking through the next week and ready to re-engage on the 7th.
Thanks, Emma. And hi, everyone. I'm Heather Baumgartner, and I lead Tri-County Health Department's Community Health Promotion Division and have the pleasure of supporting our mental and behavioral health work in a variety of ways. As we come to the end of day one, I'd like to start by expressing my sincere appreciation to Emma, as well as Monica, Summer, Patty, and the entire planning team for serving as a catalyst for bringing together such an amazing, engaged, and committed group. Our presentations today, the individual stories, and the questions posed allowed me to learn new information, make connections, and reflect on the vast amount of knowledge and leverage points that we have available to support our upcoming work together. To everyone who joined us today, thank you. I value you greatly. As someone who identifies as neurodiverse and whose family has directly experienced issues related to depression, addiction, and suicide, my appreciation for your engagement, urgency and vision is both professional and also personal. As we know, the current mental and behavioral health challenges and inequities being experienced by our families, communities, and organizations are significant, and there is no denying that the past 2 years have made our work in this arena even more critical. We are coming together as a collaborative in the midst of an extraordinary upsurge in both need and possibility. I'm greatly inspired by the connections and momentum already underway at both the state and local levels, and I'm looking forward to what the power of an agile, engaged, and interconnected collaborative can achieve. As a next step, I look forward to seeing you 1 week from today on Monday the 7th from 1 to 4 p.m. for the second half of this Mental Health Collaborative Summit. Thank you again and have a wonderful day.
Awesome. Thank you, Heather. And thank you all again. Just really echo those words of appreciation. And we're going to wrap up 3 minutes early, which I did not think was even possible. So please enjoy your day. And we look forward to seeing you next week.